The NALA trial was an open-label phase 3 study. It enrolled 621 patients with metastatic breast cancer, HER2 positive, centrally confirmed. Patient characteristics were well balanced at baseline. Nearly 80% of patients in each arm were aged less than 65, and about 80% in each arm had visceral disease. Almost 70% of patients had at least 2 prior lines of HER2-targeted treatments for metastatic disease, while about 30% had 3 or more. Patients were randomized 1-to-1 to either Neratinib plus Capecitabine or Lapatinib plus Capecitabine, and patients on the Neratinib arm also received antidiarrheal prophylaxis with loperamide, and the co-primary endpoints were progression-free survival and overall survival. A landmark analysis showed that the progression-free survival curves started to separate after 6 months, with the 6-month PFS rates being 47% versus 38%. And a pre-specified restricted means analysis for PFS was conducted and was limited to follow-up of 24 months, showing an improvement in PFS of about 2 months with the addition of Neratinib as compared to Lapatinib. It was 8.8 versus 6.6 months. Finally, overall survival, there was a numerical but not a statistically significant benefit documented with Neratinib. Other endpoints, including objective response rate, clinical benefit rate, median duration of response, all favored Neratinib as compared to Lapatinib. And I would say most importantly, there was an increase in time to intervention for symptomatic disease of the central nervous system. So this is certainly a clinically meaningful endpoint for patients with in the metastatic setting. And I think, although not definitively proven, it may also have implications in the adjuvant setting. So as a reminder, the therapy is also approved. Neratinib is approved in the extended adjuvant setting. And for patients that are at extremely high risk for recurrence, for example, those that have had neoadjuvant treatment and have significant residual disease, we know that the use of T-DM1, as shown in the Catherine trial, did not impact the incidence of CNS metastases in those patients. So this data really begs the question, are there patients in the extended adjuvant setting who are at extremely high risk of relapse even in the brain that may benefit? Again, this could not be demonstrated definitively in the Extenet trial, but it is something to think about. In terms of toxicities, it's important to realize that dose reductions and holds in this study were comparable in the 2 arms. There was a higher rate of grade 3 diarrhea with Neratinib, 24% versus 13%, but treatment discontinuation due to diarrhea was similar, about 2.5% in each arm, and the median cumulative number of days with grade 3 diarrhea was 4 in each arm.